Well, good afternoon to everybody, and thank you very much for your interest today. You may be wondering why a forensic pathologist is here, because after all we do is go out to homicides and dig around in mud and look at skeletons. But in fact in Scotland that is an unusual occurrence for us, and our job actually for the fiscal, the majority of our work involves non-suspicious deaths. So the perception you might see on the television or in novels would really apply to my colleagues south of the border who only do autopsies on suspicious deaths. So as part of my regular job, I am faced with the types of cases that we discussed earlier, the sudden death of a young person, sudden unexpected death. What I'm hoping to do in my presentation is just cover one or two issues that perhaps we as pathologists think are appropriate to this topic. I'm going to focus a little bit on the background of sudden cardiac death, albeit John has already covered most of this and in greater detail. The second bit is the cardiac autopsy. What should I be thinking of as a forensic pathologist, as a pathologist who undertakes an autopsy on somebody where there's a possibility that their death is due to a hereditary cardiac condition? Thirdly, I'm just going to discuss briefly the feedback process. What happens when we've completed our autopsy? How does the message get back to the family that they need to consider family screening? And finally, cover perhaps the areas that we're all here to consider today, the grey areas. And these are grey areas that perhaps I perceive as a pathologist and other people, other clinical colleagues might have different opinions upon. A slightly different definition of sudden cardiac death, but a sudden unexpected death of an adult within 1 to 12 hours of well-being with no history of cardiac disease. And if we look at the incidence of such fatalities, it's about 1 in 1,000 in developed countries, which equates to about 500 deaths per year in the under 30s in the United Kingdom. By the very definition of that they are sudden and unexpected, they should be referred to the coroner in England and Wales or the fiscal in Scotland. Again, they're unexpected, so they need some form of investigation, legally. Dependent upon the age within the bracket that we discussed earlier, 1 to 40, in the majority of cases, a post-mortem examination, and by that I'll come on to what I mean by that later. This is other investigations, perhaps microscopy of tissue samples, toxicology, other investigations. In the vast majority, a cause of death will be established. However, in about 4% of cases, no clear cause will be found despite a raft of investigations, both at the time of the autopsy and subsequent to it. And that we would refer to as pathologists as the negative autopsy. How will this be certified? Well, one way of reflecting that in the cause of death is a term called sudden adult death syndrome, which you may all have heard of. Another similar term, sudden arrhythmic death syndrome, which particularly refers to arrhythmia being the presumed underlying cause. And the estimated prevalence of this condition in the UK is 0.16 cases per 100,000 of the population. Apologies, I have the same virus as John. As we've already heard, there is an increasing awareness now that many of these conditions are due to inherited genetic cardiac diseases. We've covered these already, or certainly some of them. The channelopathies, conditions where there is an irregularity of the heartbeat. Cardiomyopathies, conditions where there is a problem with the actual muscle of the heart that causes sudden cardiac death. And there are other rarer conditions as well. So that's the background. The cardiac autopsy. As a pathologist, what should we be doing? Well, it's inherent that we perform a complete and thorough post-mortem. As we've already heard, there is an option in Scotland for a view and grant autopsy. This autopsy would involve us looking at the body externally only and looking at essentially excluding criminality, then again taking the medical history into account, essentially a best guess cause of death. As has been discussed, in some cases that is appropriate. We have people with well-established known diseases that can cause sudden death, but perhaps the GP is unaware that that condition can cause sudden death. Therefore, in the interest of the family, both the physical and the pathologist may deem a dissection of the body as being unnecessary. However, in the cases we're discussing today, that is inappropriate because we will not get to the bottom of what we're looking for. All autopsies, suspicious deaths or otherwise, are performed in the same standard manner. There is an external examination of the body and then an internal examination, dissection of the organs. As part of the autopsy, however, there are a number of other investigations that we can do which can help finalise the cause of death. Histology, this is tissue samples from the organs, very small tissue samples to look at under the microscope. Toxicology, samples of body fluids to look at for drugs, which may be relevant in some deaths. Neuropathology, these are samples of brain, spinal cord tissue, again referred to an expert neuropathologist to look at for underlying causes of death. And in the age brackets we're looking at today, for example, sudden unexpected death in epilepsy or SUDEP is a consideration in young people. Finally, genetic sampling, why we're here today, the reason we're having the discussions. Taking of tissue samples for prospective genetic analysis as part of the autopsy process. As pathologists, we also have to be aware of undertaking a detailed examination of the heart. There are guidelines from the Royal College of Pathologists as to how to dissect the heart, what histology samples to take in cases of sudden unexpected death. We also have the Cardiac Pathology Network UK template, which is a very similar template of how the heart should be dissected and sampled at autopsy. What this involves is extensive mapped sampling of the heart, or indeed, if one's working in isolation, perhaps in an area where these cases are few and far between, simply seeking the permission of the coroner or fiscal to refer the whole heart to a cardiac pathologist. What I mean by mapping or histology is essentially what I'm trying to demonstrate here. This is a section through the middle of the heart, through the right and left ventricle, which are the two largest chambers of the heart, and the chambers of the heart that will be affected, for example, in cardiomyopathies. The black areas that you see are the regions that we will take systematically sections from to look at under the microscope. And indeed, this sort of sampling will provide perhaps 10, 12 or more blocks for us to look at under the microscope. And that should be enough for us to look to see if the muscle is normal, or is there a cardiomyopathy, or indeed another microscopic condition that we're not seeing naked eye when we do the autopsy. Genetic sampling. When we're undertaking the actual autopsy, the dissection of the body, largely based upon the history but also age of the individual, do we think genetic sampling is a consideration? In the cases we're discussing today, hopefully so. What tissues should we be taking? Well, they need to be rich in DNA so that the genetic testing can be performed adequately. And working with my colleagues throughout Scotland, there are a collection of samples now that we try and take in all cases where we deem at the time of the autopsy that this is potentially worthwhile. And these include skeletal muscle, heart muscle, blood or spleen. These are organs that are rich in DNA. Now, having focused there on the autopsy process, what happens when we finish all our investigations, when we've done all of the histology, toxicology, everything has come back, and essentially we have a negative autopsy. At this stage, I haven't undertaken genetic testing, or I haven't requested genetic testing. Well, it's important that we realise the implications of a negative autopsy, particularly in young people. Again, taking it back to the history that we have, a young person collapsing suddenly. we have to bear that in mind, that there is a potential for an underlying genetic condition that has caused that individual's death. The way this process works, however, is that my final report, when I produce that, will go to the fiscal. And then it's actually the fiscal's responsibility to then contact the family, instruct them of my final cause of death, and also pass on the information to them that genetic screening should be considered. Now obviously, knowing that that's the process, there is an inherent responsibility upon us as pathologists to make it very clear in our post-mortem report, in the conclusion of our post-mortem report, what we mean by the possibility of an inherited or underlying genetic condition, and what the implications are for that family. Obviously, that hopefully ensures that the fiscal, who after all is a non-medical person, they are legally qualified, firstly they understand what we mean as pathologists by that. And to help that, we obviously can consider using other means, for example, phoning the fiscal in advance and say, you're about to receive a post-mortem report on so-and-so, just to let you know that there are further information needs to be passed on to the family. Equally, what we've developed recently is an extra letter in local practice that goes with the post-mortem report, a second piece of paper, if you will, to say to the fiscal, please bear in mind the family need to consider screening. It's also important for us as pathologists to make the report understandable to the family. We are medical professionals, however our reports are for the fiscal and for relatives, and we have to always remember that. So we have to try and use understandable language for anybody who's going to have access to the report, and in most cases the report won't be accessed by medical people subsequently. We should also be willing to meet with the relatives to discuss our post-mortem findings, and again to clarify any issues they may have as regards the cause of death and what that may mean for them as a family. Finally, the grey areas I guess that myself and my colleagues perceive in the process as it stands at the moment. Well, these are things we're trying to address through the fans network, through regular meetings with that group, but also through local practices with our own death units and our own fiscals. And the aim there, obviously, is to reduce the number of families that may slip through the genetic screening net. Firstly, when to take genetic samples at post-mortem? Well, we've already heard that there is an argument for all cases where the initial cause of death, so at the time of the post-mortem, my cause of death is unascertained. So at the time of the dissecting the organs, I haven't found an obvious disease process that has caused this young person's death. However, simply that creates practical issues. In my previous job in Glasgow, for example, that may be 500 or 600 post-mortems a year, where initially the cause of death is unascertained. But based upon the medical information available at the time of the autopsy, in 590 of those cases, I have a good idea that toxicology is going to provide a cause of death, because we have in Scotland a high drug and alcohol problem. It also means that there needs to be a national approach as pathologists and working with the fiscals as to which cases we take samples in. Is it all cases? Will it be accepted by the fiscal that we will take samples in all unascertained cases? Or will it be simply our professional judgment? We've touched upon the implications of tissue storage in the Human Tissue Act. And as pathologists, we're aware that the Human Tissue Act in Scotland is a little bit more flexible than the similar act in England and Wales. However, we still have to bear in mind that the samples we take are essentially for diagnostic purposes. And as I've alluded to already, in many cases where the initial cause of death is unascertained, we will subsequently provide a cause of death. And therefore there are a large number of cases where we will have taken tissue for prospective DNA analysis unnecessarily. It won't be used for that purpose. Have we broken the Human Tissue Act? I don't believe we have, but we have to be very careful, and obviously as pathologists we are the ones who have been involved and criticised in incidents such as Alderhay. Another issue that crops up when we discuss these problems at our fans meeting is the standardising the cause of death. As pathologists, we may use a variety of terminology to essentially say somebody's died and we don't know why. The reason for that, terms such as sudden adult death syndrome, presumed cardiac arrhythmia, unascertained, these will all go on the final cause of death to the family. Which term we use often depends upon the circumstances or the amount of information we've been given about the circumstances in which somebody died. If it's a witness collapse of a young person, then it would appear to be a cardiac arrhythmia. But if it's somebody who's gone to bed, was fit and well when they went to bed, and is found dead in the bed the next morning, then it may not be as clear-cut as, oh well, this presumably was a cardiac arrhythmia. As I've already said, for example, sudden unexpected death in epilepsy can occur, a seizure during the night that causes the heart to stop. So perhaps in that instance where the death is unwitnessed, one may use the term unascertained. What it does mean, however, is when statistics are trying to be gathered as to how many sudden arrhythmic or sudden adult deaths there are per year, they will be inherently inaccurate. Finally, the links between the pathologist, the fiscal and the family. This needs to be tightened. Perhaps pathologists need to be more directly involved in liaising with the families. As we've discussed, however, the system as it stands is that our reports are the property of the fiscal. The fiscal is responsible for investigating the sudden death, and the PM report is technically their property. Perhaps the PFs also require extra education about sudden cardiac death and what the implications of it are to families and what their role is in that chain to the family. Thank you very much.